今日のケースやっていきましょう。今日は、A 32-year-old female with a facial laceration after a fall ということで、32歳の女性、転んだ後に顔に傷ができたというので受診されているということですね。この場合は、素直に言えば、顔の傷で患者さんは来ているということなんですけど、なんで転んだのかっていうところがポイントになるんじゃないかなっていう気がします。History of present illness. The patient initially presented to the ER about 2 hours after she suffered a fall that morning. She bought a new bed and miscalculated the height while getting up. She fell, striking her forehead against the metal bedside nightstand, causing a laceration. She remembered the entire event. After the fall, she went to the emergency department but left after waiting too long. She represented 2 hours later due to persistent symptoms including vertigo, nausea, frontal headache, photophobia, and tinnitus. Denies loss of consciousness, neck pain, emesis, shortness of breath, or other symptoms. なるほど。あまり関係なかったですね。普通に、新しいベッドを買って、うっかり落っこしてしまったと。で、それで、おでこをぶつけてしまった。で、それで、ER を受診したんだけれども、すげえ待ってる間に調子悪くなっちゃったみたいな感じなんですかね。さて、どこから入ろうか。ただの切り傷じゃダメなんですかね。あとはでもめまいとか吐き気とか、っていうことが出ているので、persistent symptoms でこれに関しては、めまいはいいかもしれないけど、nausea があるということは頭蓋内圧更新が出ているということを示唆しているのかなというところと、あとフォトフォービア、これがちょっと悩ましいところなんですけど、後頭葉にも何か刺激が出ているということなんですかね。前頭葉を打った場合、後頭葉に血腫っていうこともあり得るとは思うので、単行部はね、ぶつけた場所にできるんですけど、いわゆるコンカッションとか脳挫傷みたいなものとか出血とかは反対側にできることもあるので、そういうところが、引っかかってるんですかね。素朴なコンカッションではなくて、ヘマトーマがあるかどうかというところになりますかね。acute epidural hematoma 出てこないですね。なんでかな。next いきましょうか。Next, medical history, past medical history, none. Post-surgical history, bilateral tubal ligation and cholecystectomy, medications none ということで、両側の卵管結紮、避妊ですかね。それと、あと、胆の切除をやったことがある。それ以外は特にありませんということで、特に出血傾向を認めるような飲み薬とかはないということを言わんとしてるんでしょう。Physical exam, vitals, 106/71, blood pressure, and 86 pulse, 16 respiratory rate, 100 O2 sat on ambient air, and temperature 37.0 degrees Celsius. General mild distress. Skin. There is a 2 centimeter vertical linear laceration to mid-brow without active bleeding, no battle sign, supple neck without posterior cervical tenderness, neck supple, no nuchal rigidity, no tenderness to ROM. Range of motion ですかね。これはネックですから。で、hand, PERRLA, EOMEI。これは、対向反射に、両側、迅速で左右差なしと。で、動向も円形ですということを言ってますね。で、あとは、extraocular muscle intact ということで、外眼筋の動きには特に制限ないということを言おうとしているんでしょう。No nystagmus, no hemotympan ということで、いわゆる耳の中に血が出たりもしてませんということなんでしょうね。 respiratory, clear to oscillation bilaterally, no rails, rhonchi, wheezes, 今日は大丈夫。regular rate and rhythm, no murmurs, rubs, gallops, 2 plus pedal pulses, back normal inspection, full ROM, no midline tenderness, musculoskeletal, no evidence of trauma and full range of motion, 2 bilateral, upper extremities and lower extremities, neural, alert and oriented, time 3, normal sensation and motor to bilateral upper and lower extremities ということで、ちょっとこのあたりで、女性が、外傷できているので、何かしらいわゆる例えば家庭内暴力とか、そういったものがないかなというのも確認しているようですね。他の外傷がないかなっていうのを確認したりしていると。でもあんまりはっきりしたものはなさそうですね。Labs, CBC, CMP both within normal limits. PT, normal. INR, normal. PTT, APTT ですね。normal. Further hospital course. On reassessment, 15 minutes later, the patient complained of worsening dizziness. I feel the room is spinning around me, while she was seated and kept her eyes closed while answering these follow-up questions. ということで、めまいが強くなってきていると。これ耳の症状が強くなっているということを考えれば、側頭部にも何か、出血なり、何かあるということを考えた方が良さそうですね。Imaging, CT brain without contrast, minimal traumatic subarachnoid hemorrhage along the anterior aspect of the frontal lobe ということで、急性硬膜下血腫じゃなくて、くも膜下出血だったという症例だったですね。そうですか。答え書いてあるからね。Dural hematoma もやっぱり残りますよね、コンカッション。Teaching points. Case resolution. Despite not meeting the initial imaging criteria according to the Canadian CT head injury rules, the CT was so due to her persistent vertigo, not a part of the criteria. For imaging, the abnormal CT prompted a consultation with the trauma surgery team who recommended admission for overnight observation and further management. Her overnight stay was without incident other than one emesis episode. Her symptoms improved and she was discharged next day with antiemetics and symptomatic treatment. Re-imaging was not obtained due to the small size of the subarachnoid hemorrhage and the improving symptoms. Background traumatic brain injury remains a leading cause of morbidity and mortality worldwide, accounting for approximately 2.5 million TBI-related emergency department visits in the United States in 2014. Mild TBI, defined by Glasgow Coma Scale score of 13 or higher, accounts for 70 to 90% of TBI cases worldwide, with some studies indicating a GCS of 15 as the most common presentation to EDs. The commonly studied sequelae of mild TBI include isolated TSAH, subarachnoid hemorrhage, defined as the traumatic subarachnoid hemorrhage, defined as the exclusive presence of traumatic ZAR in the absence of any other traumatic radiographic intracranial pathology. Common mechanisms leading to TZAR include motor vehicle crashes and fall from height. For the emergency medicine physician, the diagnostic workup and management of MTBI patients rely on a thorough history and physical examination. After evaluation and examination, the risk-benefit ratio of pursuing CT imaging will be weighted with the assistance of clinical decision tools as needed. Etiology. The incidence of isolated traumatic ZER as a sequelae in mild TBI patients remains low, with one study reporting an incidence of 3% out of a sample size of 1149 mild TBI patients. It is a goal when evaluating patients following a head injury, when it even appears to be a minor one, to determine which patients merit imaging. The two commonly used clinical decision rules are the Canadian CT head rule and New Orleans criteria. Both of these studies initially enrolled patients with traumatic head injuries that involved the presence of a loss of consciousness. Clinical symptoms. Common symptoms of ZER include severe headache, sometimes described as thunderclap, nausea, and vomiting, cranial nerve palsies, and neck stiffness. The neck stiffness often develops several hours after the initial injury. In severe ZER, altered level of consciousness and hemiparesis are present. In aneurysmal ZER, patients may have a sentinel headache days to weeks before the presentation. Management. The usual care for patients with TBI with evidence of intracranial hemorrhage includes neurosurgical consultation, admission to the ICU or neuro-ICU, and evaluation with a repeat head CT scan 6 to 24 hours after the initial study to evaluate for progression. Patients with traumatic ZER and mild TBI GCS 13 to 15 are considered a low-risk population for progression and interventions, as studies in this group have found that less than 1% of this population required any form of neurosurgical intervention. Thus, some clinicians have adopted a more conservative approach in those with mild TBI and found that selective and opposed to routine repeat head CT scans led to decreased hospital LOS without impacting GCS. Clinical Pearl. This case highlights that clinical reasoning should be used in conjunction with clinical decision tools. Applying the Canadian CT head injury rules allows physicians to safely reduce head CT imaging by around 30%, while the CCTHR is 100% sensitive for finding injuries needing immediate neurosurgical intervention. It can miss small subarachnoid hemorrhages and small subdurals. The New Orleans criteria is more sensitive but less specific. Clinical parts 2. Unlike non-traumatic ZER, nimodipine is not recommended in traumatic ZER due to lack of benefit in several studies. ということでした。ということで、日本はCT 取らない理由ってあんまりリーズニングされにくいですけど、やっぱり保険の都合、お金の都合もあって、やっぱり諸外国では、CT をいかに取らないか、で取らない理由をリーズニングするかってことは非常に重要なんでしょうね。日本だとね、なんで救急外来来たのに、何かあった時になぜ取らなかったんだって一例でもあると、やらない理由ってもうどうにも理由付けできないっていう状況ですからね。この辺悩ましいですね。このケースはこれで終了にしましょう。お疲れ様でした。